in the eye, you can unmute. You may switch off the videos, but you can unmute. Microphone එක දාලා අරගෙන තියන්න. You can talk to me at any time. ළමයින්ගේ ගොඩක් කට්ටිය මයික්‍රොෆෝන් එක මියුට් කරගෙන ඉන්නේ. මොකද මට ප්‍රශ්න අහපුවම ඔයගොල්ලෝ සැරසැරේ කතා කරන එකට මම කැමතියි. ඒතර ලේසි. This is not a formal lecture on the other hand. So anytime you can ask questions. ඔයගොල්ලෝගේ බැච් එකේ ළමයිම නේ ඉන්නේ. ඒ නිසා ඕන වෙලාවක disturb වුණාට කමක් නැහැ. මගෙන් questions අහන්න. එතකොට තමයි I can take you. The red eye is just like the brain responds to any injury swelling. The eye also, the response is most of the time redness. How does the redness appears? But how do you think the redness appears in the conjunctiva? Students, why do you get this? This is red. Why do you get this redness? If you take this one, it's red. Why? කතා කරන්න කවුරු හරි කමන්නේ ඕන කෙනෙක් කතා කරන්න.
Because of the inflammation.
Yes. Okay. What inflammation? Why it is red? True. You are true. You are correct. Why?
Dilated blood vessels.
Of course. Then why the eyes become very red compared to the other part of it? When you get an inflammation in the skin and all that, you don't get that redness. But in the eye, you can see in this picture, you see all the blood vessels are anyway visible. You understand? Lot of capillaries and tiny blood vessels on the conjunctiva are visible. Right? There is no much melanin pigmentation like in this. These are translucent membrane. All the blood vessels are clearly visible, and as a result, you can the response is inflammation. Right? So the response is swelling. The blood vessels enlarge, then you can see the redness. Okay. Now you have the redness appears on the conjunctiva. Conjunctiva has got two parts. What are the two parts that, as you are aware, bulbar conjunctiva, that is on the bulb. That's called bulbar conjunctiva. The other one is palpable conjunctiva, which is on the inner surface of the lid. If you take the inner surface of the lid, you get the palpable conjunctiva, right? It's not here when you come up. So that's palpable conjunctiva. So you have got two important areas in the conjunctiva. This area is called palpable conjunctiva, and this is called bulbar conjunctiva. That is important. That's why when we are discussing the red eye, very important to identify which area is more red. Depending on the cause, the redness will be different. Okay. Now, what do you think the causes for red eye? Very easy. You don't have to remember too much. Hold on. Now, if you take this slide, you can see the causes. If you take from the front, and you take it from the front, conjunctiva per se can cause the redness. Some problem in the conjunctiva, maybe trauma to the conjunctiva, maybe due to viral infection of the conjunctiva, inflammation, bacterial infection can cause inflammation, or some foreign body in the conjunctiva can cause irritation, or simply rubbing the eye can cause inflammation in the conjunctiva, and that can cause redness. So it's some problem can be in the conjunctiva. And then what is the next nearest the tissue in the eye? Cornea. So any problem in the cornea can cause again redness. The very important to remember that the conjunctiva, the cornea is very, very sensitive organ in the body, right? Very painful. Even a tiny abrasion can give rise to severe pain. So in addition to that, it causes inflammation. So conjunctiva can cause redness. Problems in the cornea can cause severe pain and inflammation. And similarly, under the conjunctiva, you know that there is a episclera and sclera. Under the conjunctiva, you have a tiny loose areolar tissue kind of thing, which is called episclera, and after that you get the tough whitish shell, which is called the sclera. So any of those two tissues also can get inflammation due to any conditions, like in arthritis you can get scleral swelling or inflammation. Celli you can get inflammation in the sclera or even episclera. So that's called inflammation of the episclera, you call episcleritis. Inflammation of the sclera is called scleritis. So any of those things can cause redness. So your sclera or episcleritis or scleritis can give rise to redness. Right? And then you go to the inner, anything inside the eye also can cause inflammation. What are the structures inside the eye? The first thing is iris. Because we have already spoken about the cornea, next layer is the iris. Swelling in the iris, iritis, or inflammation in the iris can give rise to redness in the eye. I will explain how you differentiate those things little later. Or else, if there is a blood in the anterior chamber or any other inflammation due to uveitis, the anterior chamber itself can get inflamed. So in that case also eyes become red. And then behind that, what are you get? You get vitreous. Vitreous also can cause inflammation, but just simply because the posterior chamber is involved behind the lens, conjunctiva will not become red unless it diffuses to the anterior chamber. So anything in this area can cause redness. Can anybody tell me if you get a severe eye pressure, can that also causes inflammation? Yes. Acute angle closure glaucoma, severe inflammation because of the pressure. There is kind of a ischemia, severe pressure, and that can give rise to inflammation on the front part. So I told you the red eye causes are some problems in the conjunctiva, some problem in the cornea. These things you don't have to forget, and you can. I mean, you don't have to remember very hard because I'm also just working out either cornea, conjunctiva. Underneath that, you get the episclera or episcleritis, or behind that, you get the sclera or scleritis, or anything inside the eye can cause red eye. So, very simple classification. Okay, now we will identify how you differentiate those things. We'll take the conjunctivitis first. Right? Okay. What do you mean by conjunctivitis? It is the inflammation of the conjunctiva. It can be due to very commonly viral conjunctivitis. Right? The patient comes with what are the symptoms of what are the causes? One student answer me. What are the causes for conjunctivitis? Now we are discussing the first cause for the conjunctivitis: inflammation or infection. Even infection give rise to inflammation. So finally, inflammation of the conjunctiva. Conjunctiva. We are going to go out of that. We assume conjunctivitis. What are the causes for conjunctivitis?
Infection.
Very good. What infection?
Could be bacterial or viral.
Yes, very good. Bacterial infections, viral infections, parasitic infections. So same, your list can be to, in your fungal infection. Out of that, parasitic and fungal infection and protozoal infections are there, but not common. So you can put them very low, but viral conjunctivitis is the commonest. That is which is contagious. So hamatanam spread any just viral conjunctivitis. So viral conjunctivitis is the commonest, right? What are the symptoms of viral conjunctivitis? If a patient comes to you with a red eye, first thing that you have to come to your mind is viral conjunctivitis. Fair enough, because it is so common. And that you can work out without, and no eye surgeon will look into the virus or so, do histology, nothing. We will also get the history and symptoms and we diagnose it is viral conjunctivitis. What are the what is the history? History will tell, okay, mage gedara kaata hari tibuna. I have a contact history, conjunctivitis. Most of the time, or sometimes it may not. Bus එකේ ගිහිල්ලා බිත්තිය වර පොල්ලක් අල්ලන් ඇවිල්ලා අත පියදානවා, you can get. It is always, it has to be direct or indirect contact. So most of the time you can have a contact history. Number one. Is it unilateral or bilateral?
Mostly unilateral.
Mostly bilateral.
Could be
Because,
unilateral.
sorry? I think it is bilateral. Initially unilateral, yes, but very soon it involve the other eye also. One eye usually, very close to the other eye, so infection goes to the other eye, either unilateral or bilateral. Most of the time when the patient comes to you, it is bilateral conjunctivitis. Both eyes. As dekama ratu elane mehema karagene inne. So you very commonly bilateral because it's so infectious. From one eye to the other eye, it infected. So bilateral, initially yes, as you said correctly, it may be unilateral, but commonest is bilateral. So bilateral, red eye, what else? Are there discharge or not?
Yes, sir.
So much of discharge. Is it watery discharge or mucopurulent discharge?
Water.
Very good, because it's watery. If it is a bacterial infection, you will get a mucopurulent sort of discharge. So therefore, you remember that it's a watery discharge, red eye both eyes, and irritation and swelling of the eyelids. And what will happen to the vision? Anyone? What will Sakya?
Nothing happens.
Yes, yes, Malisha, yes. Okay, what will happen to the vision?
There will be less. There will be no or less visual symptoms.
Very good. The vision usually, because this is conjunctiva, vision is not affected. Vision is very good. So you can diagnose easily viral conjunctivitis. I will tell.
Nothing happens, sir.
Yeah, nothing happened. Yes, you are correct. Vision is good. Vision is maybe 6/6. Body, there may be because of the tearing and discharge, there may be 1 or 2 lines drop off the vision. But again, patient will be able to read everything. Previous vision will stay. So vision is not affected. Bilateral, watery discharge with severe red eye, and very important, sometimes hemorrhagic conjunctivitis, sometimes subconjunctival hemorrhages, especially coronavirus can cause, rotavirus is the commonest cause that causes hemorrhagic conjunctivitis. Rotavirus can cause that sort of hemorrhagic conjunctivitis. The epidemics that usually we get viral conjunctivitis, you get hemorrhagic conjunctivitis, severe swelling. And sometimes these are beyond the common things. Sometimes you get somewhere here membrane formation. And if you look carefully, there is this sort of papillae. These are papillae. You can see the follicles. So can you see tiny follicles, lymphoid follicles? So this is how you get when you pull the lower lid down, you can see this. Right. Important thing, once you do that, you have to wash your hands either with soap and water. Almost all the viruses die with the soap and water. You can get rid of that. Otherwise, you have to use this thing. Otherwise, you will infect the next patient. So okay, now very good. Now you can tell you the viral conjunctivitis. Commonest type, bilateral, watery discharge, vision is not affected, severe pain, mokut naha. Avilla kiyana, mehem tiyena, amaru ikela kiyana. That's all viral conjunctivitis. If it is bacterial, very difficult for us to differentiate, in fact, whether it is bacterial or viral. Bacterial conjunctivitis is not that common. But if it is bacterial, you will see kudak metana kaba pirila discharges. Right? You can see that. Next one, that's bacterial conjunctivitis. And out of that, important group of bacterial conjunctivitis is there. We will discuss it, that ophthalmia and neonatal after this. Okay, how do you treat this conjunctivitis? Now, we don't know whether it is viral conjunctivitis or bacterial conjunctivitis. There are controversial things. Sometimes some people say use antibiotic because it can, if you use steroid, it can, secondary infections are common. Those things will not affect, right? So you can use the commonest thing that we use, antibiotic and steroid, both we use, right? If it is, we are sure it's a conjunctivitis, our aim is to control the inflammation. Why? The steroid will control the inflammation. Antibiotic may or may not use. Usually, they know secondary infection as such, but we are also, to be on the safer side, we use an antibiotic. I usually use combination antibiotic and steroid, tobramycin and dexamethasone. There is a good brand called Tobradex. That sort of thing we use. So once you start that, very frequent drops every 4 to 6 hours, you put one drop and put the medicine and apply the cold compressors. Take not the hot water, anyway, cold water, just to make the swelling or inflammation reduce. So you apply the cold compressors. That can relieve the symptoms patients. And the important thing, now I told you put drops. How do you put the drops into the eye? Now inside the eye we call it the gutter. Gutter එකක් තියෙනනේ. Conjunctival sac කියලා කියන්නේ when the eye is closed, between the eyelid and the globe of the eye, there is a potential space, tiny space. In that space, you can accommodate only about 30 microliters. 30 microliter means one drop of any fluid. So if you are putting more than one drop into the eye, this is a very frequent question that every patient asks from us: how many drops? You can put any number of drops, but no point, it will spill over. So therefore, when you're putting the drops into the eye, you will put one drop. You can put any number of drops, no harm, because the moment the patient blinks, the rest will disappear, go out, overflow over the eyelids. Therefore, one drop at a time. Usually 4 to 6 hours intervals, you can put the drops. Unless it is an ulcer or anything, we can put frequent drops. You can put any number of drops. So one drop, 4 to 6 hours is done. Other important thing, when you're putting the drops, you don't have to put exactly on the center of the cornea. I'm just giving you general guidelines how to put the drops onto the center or anything. Just pull the lower lid and put into this gutter. That's enough. Once the patient blinks, the fluid spread all over the eye. If you are leaving the conjunctivitis aside, and if you put glaucoma drugs or anything which you aim the drops to penetrate into the eye, you have to squeeze the center of this lacrimal puncta here at the nasal end of the eye, the angle of the eye. You just press like that or tightly close the eyes and wait for about 1 to 2 minutes so that the fluid get absorbed into the eye. Otherwise, what happens, the drops that we put will go into the nose through the the tear excretory pathway. So very important. That is how you put the drops. And when you are putting the drops, these are general things, even in your general practice or even as house officer, you have to admit. When you remove the bottle cap, you should not keep that on the table because that will contaminate germs. So keep the other way. So you should not keep, because the next time when you close the lid, if it is contaminated, it can go into the solution, especially when you are putting the steroid or glaucoma drugs. But antibiotic is a different story. Right, fine. So you know how to manage viral conjunctivitis, how to put the drops, and you know how to diagnose the bacterial conjunctivitis. Those are conjunctiva. Those are the commonest things for the red eye. The other conjunctival causes that red eye, patient napu gamang asrat weno kiyala. That is not a pathology, because when you put the cold water onto the eye, the blood vessels get constricted due to reduce the loss of heat. And then the moment you stop bathing and come back, now suddenly the front part of the eye find the blood is not adequate. Then reflexly conjunctival blood vessels get dilated. That redness is there. After maybe 1 or 2 hours, it disappears. It is not a serious condition, or it's not an abnormality. That's a normal physiological reaction. So you can tell the patient and reassure patients. And sometimes you get patients comes in, I think, very deep, this sort of thing. This is a very common thing. The patients, every day I see at least 1 or 2 patients like this. This is what do you think this? Anyone?
Hemorrhage.
Yeah, what hemorrhage? It is subconjunctival hemorrhage. Hari, this is called subconjunctival hemorrhage. This is how I explain the patient. Now, this is the conjunctiva is like a lunch sheet, tiny membrane. The story also true. What I'm telling the patient is true actually. So it's a very tiny membrane, but underneath there is a potential space. If you get a tiny blood vessel, blood drop, that quickly disperse everywhere. When you put a water drop into the plate and put the lunch seed, the water spread everywhere. It diffuses and it appears like a large area of water. Similarly, in conjunctiva also, it happens like this. This is subconjunctival hemorrhage. And you can see very clearly the rest of the, if it is an inflammation, you will never get clear boundaries like that, right? You get somewhere here also. So therefore, this you get redness, very, very deep red. You can see the blood, and even the blood vessels are not visible so deep, and it bound. You can see the blood is diffusing. Yeah. Sometimes the whole eye can become red, but still, patient will not have symptoms other than he sees when he goes to the mirror, or someone else would have frightened the patient to come to you. Otherwise, they are asymptomatic subconjunctival hemorrhage. You don't have to investigation. Even if the patient comes with bilateral subconjunctival deep hemorrhages, only the first question that you have to ask any intelligent, any clever student, what is the first question that you would ask? You have seen a lot of children, if you go to the pediatric ward like that, both eyes become red sometimes. Subconjunctival hemorrhage. Any question? Any student? What's the cause? Cough.
Cough.
Very good, very good. Cough. Sudden coughing can such as increase the intrathoracic pressure and hence intravenous pressure and reflux the blood. Most of the blood vessels that you see here is veins. So you get one or two veins ruptured inside the eye. This will not happen in the brain or anywhere else because these are superficial tiny vessels which have no tissue covering and all that. They rupture. The moment it ruptures, blood spread everywhere. But parts of the body will not, in the head and neck area, will not happen like that because they are covered and more tissue covering or tissue wall also is there around the capillaries. So even if a blood vessel ruptured, it will not bleed because there is no such a potential space to bleed. Quickly they clot, but not in the conjunctiva. So you get sudden coughing, raise in thoracic pressure for any reason, weight lifting or anything. Or otherwise, the next question is rubbing the eye. That also can cause. Next question is when the patient sleep like that, the mosquito bites here. So that's also not uncommon. And you don't have to investigate unless it is bilateral, diffuse, and very frequent. Then the only thing that you have to investigate whether there is a bleeding disorder, right, or clotting mechanism abnormality. Otherwise, you don't have. Or severe hypertension can cause this, but those are very uncommon. I have not seen maybe one or two patients for my how many years now, more than 20 years of ophthalmology practicing. So very unlike. So how will you manage this patient? But I say the patient, I'm very happy to see you, and this is the, the God given patient. I make the patient smile and say, this is I have no risk of managing you at all because I don't have to give anything other than explaining what it is, and 5 to 6 days time it will disappear, maybe maximum 2 weeks. That's all. And you have to tell tomorrow probably this will increase little more because one thing is if it is still bleeding, or sometimes the already blood can diffuse, so therefore it can increase a little bit. Tell the patient will be very happy, and in the next time also the patient will be coming to you. So that's also important in your practice one day, right? Okay, fine. So these are subconjunctival hemorrhage, right? So we have finished the conjunctival redness. And one important thing, in any of these conjunctivitis, pull the lids and see the redness is more on the lids, palpable part, than around the cornea, than closer to the cornea. Why? The reason is because the inflammation is more on the conjunctiva, not around the limbus. If you get the inflammation and redness more on the lid, around the cornea, around the limbus, we call it circumcorneal injection or inflammation around the cornea or limbus. That indicates the cause for the inflammation coming from the inside the eye, not from the conjunctiva. So very important to see. If you get, for example, uveitis or infection inside the eye, which is known as endophthalmitis, or any foreign body on the cornea, or right, then your redness will be more around the cornea, conjunctiva. Palpable, we call it perilimbal or circumcorneal injection or inflammation or redness. But not much on the lids. When you put the lids, pull the lids and see, sometimes even that may be white. But on the other hand, if it is pure conjunctivitis, lids will be more red than around the cornea because the main pathology is in the conjunctiva in that sense. Okay, so that is how you differentiate conjunctivitis. And this is another very common condition that comes to you. What is this? Anyone? What is this? Ko unmute karena kau dah kian.
Corneal ulcer.
This one, I'm asking this one. Have you seen this? මේක දැකලා නැත්නම් අපෝ එල්ලන්න ඕන. මේක දැකලා තිබුණ තරම්. ඔය බැච් එකේ සමහරට එක්කෙනෙක් දෙන්නෙක් හරි ඇති. Especially people coming from Polonnaruwa or Hambantota. Now to make it easy. මේක ලියලා තියෙනවද නෑ ලියලා නෑ. Very good. What is this? Me? What is this? How do you pronounce this? Pterygium. This is called pterygium. What has happened? Now, if you take this eye, cornea, actually speaking, the corneal epithelium is formed by the cells around the limbus. The cell, those are called stem cells. You have the stem cells here. Every day, stem cells proliferate from here and send this side. What do you call the epithelial cells, and they become corneal, transparent epithelial cells, right? They become transparent epithelial cells. Okay, for some reason it doesn't work. And now, for any, if the conjunctiva is always trying to come and cover the cornea and grow over the cornea, but because of the barrier, these limbal cells, conjunctiva, the moment it comes here, conjunctiva will not come. Actually, cells proliferate here and form the cornea. But for any reason, if the limbal cells are damaged here, conjunctiva continuously grows onto the cornea. This is what's happening here. Conjunctiva grows onto the cornea and it gradually comes towards the center. Right? If it comes to the center, patient will go blind. So before it comes to the center, you'll have to operate this and remove this. Easy way to remove. You just cut it, dissect and cut it off, and you can graft another good conjunctiva at this place to prevent it coming back, because stem cells have to come here. Or else you can put an amniotic membrane, donor tissues, you can take an amniotic membrane. Amniotic membrane, you have the stem cells. It can, depending on the environment, it can grow into anything. That's an advantage of amniotic membrane, right? You can one day use the amniotic membrane to grow, apply on various places we very commonly use. So if you put okay, this is called pterygium. It's very common in, I told you, Anuradhapura, Polonnaruwa and Hambantota. That is where you get more windy. This is how I explain. Sandy, windy, hot environment, you get this. And sandy, windy, sunny, hot environment. UV light, when it is very sunny, bright light, what do you call, sunlight. And godak hulang enawang, eyes become dry. Godak foreign bodies dry, dust ekenawan godak, and godak hulang tiyenawan nitarama velenawane. So that can cause this sort of thing. That is why people who are in Polonnaruwa and Hambantota, ideal environment, sandy, windy, sunny environment. So the people come very often. If you see patients on the road, a lot of people. Hambantota thema, I think. So the treatment is this. Unless it is grow fast, there is no indication to remove. Many people you will live with this, but there are indications for surgery. This you cannot forget. One is if it is rapidly growing onto the center, then you have to remove it. Obviously, yes. Very, very rarely, don't keep this in mind, but very rarely, a squamous cell carcinoma also can come like this, or this can convert it to squamous cell carcinoma. Don't come with that answer in any board. The consultant or the doctor will laugh at you because it cancer ki woga mang. But if it is an abnormal growth, which is a suspicious lesion, then you'll have to remove. So if it is coming to the center, if it is suspicious lesion, you have to remove. Or if the patient having symptoms, make irritation, then you will have to remove this pterygium. Right? තව එක අවස්ථාවක් තියෙනවා. If the patient නළුවෙක් හරි නිලියක් හරි නම් patient is or බැඳලා නැත්නම් ආද ඔය ළමයි ඕගොල්ලෝ කාට හරි ආවොත් ඒක කරන්න එපා. දැන් බඳින්නකොට නැත්නම් හරියන්නේ ෆොටෝ ගන්නකොට එහෙම. So for cosmetic reasons, sometimes if the patient insists, we'll have to remove it. Right? So this is your pterygium. Remember how it's a non-malignant fibrovascular growth. Hot climates, chronic dryness, exposure to sun. මෙතනම තියෙනවා මම කියපු ටික මේක දැකලා නෙමෙයි කිව්වේ right? මේ slides මම now only see. So this is how you see that. Right. So it's called pterygium, pterygium. So pterygium treatment. What is pterygium? It's a fibrovascular growth over to the cornea. What are the symptoms? Most of the time asymptomatic, or otherwise patient can have irritation, redness. They can become red often. Those are the symptoms. What you have to do, if it coming to the center, or if it is an abnormal growth, or if it is frequently disturbing the patient, red and irritation, then you remove it. Or else for cosmetic reasons, you remove it. But is the no drops is going to help? Nothing. The only treatment is just take it out under topical anesthesia. Without you don't have to know the details, but the surgery is the treatment. Management, surgical removal only. Very good. So this is conjunctival causes for red eye. Now I have told you so much. Conjunctivitis, subconjunctival hemorrhage, pterygium also can give rise to this thing. Now we'll move to next one, corneal causes for red eye. Lot of corneal causes are there for red eye, right? Number one is, we'll go in commonest order. If you get a foreign body, that's even you all have got it. If you get a foreign body onto the cornea, you get red eye because that causes inflammation, sort of an early ulcer. You can see it here on this my lower picture. ඔයගොල්ලන්ට පේනවද මේ මගේ slides මම මේ talk දුන්නට?
Yes, sir.
All right. So this is a foreign body here. You can see this can cause redness. You can see around that patient මෙහෙම ඉන්නේ සමහරට හස්තිය අමාරුයි doctor හැ කියනවා කියලා ඉන්නේ. So foreign body on the cornea can cause redness. So then how do you manage this? What are the common causes? එකක් තමයි motorcycle එකේ යනකොට helmet එක මේ visor එක දාන්න නැතුව. එහෙම නැත්නම් අර metal වැඩ කරන තැන් වල ඉන්නකොට. එහෙම නැත්නම් කෝච්චියේ එල්ලිලා ගියාම this is very common, right? Foreign bodies. So working places, hard metal work කරන කට්ටිය ගාව එහෙම. At the same time metal work කරන කට්ටිය ගාව කියන්නේ යන්නේ is kind of a blast like injury, very hot projectiles. Sometimes they penetrate into the eye and later patient comes with endophthalmitis. If a metal, especially iron, is inside the eye, it causes chronic toxicity, which you call siderosis. Sidero means iron. Siderosis. If a foreign body iron is inside the eye, it can cause siderosis bulbi කියලා we කියන bulb කියන eyeball නේ. Siderosis bulbi or chronic iron toxicity. It has to be foreign body iron metal නැතුව අර iron overload වෙලා එහෙම වෙන්නේ නැහැ. But if it a metal foreign body inside the eye, especially iron, right? Not gold, they were inert. ඒ වගේ ගියොත් you can get the siderosis. Iron ගියොත් toxic වෙනවා, in the you have to remove it. Okay, that's deviation. At the same time, if you get a penetrating injury, immediately heal sometimes, but 3 days time patient comes with severe infection, especially children. They have to be very, very careful. You have to educate the parents, bring the child back because they don't understand us. I will tell you one story. When I'm in the eye hospital, one girl ඉදිකටු ඇනගත්ත කියලා ගියා ඩොක්ටර්ස් දෙන්නෙක් ගාවට ගියා මෙහෙම ඇහි වැදුනා කියලා බැලුවම මොකුත් නැහැ GPs one of the doctors from our faculty I know the guy මොකුත් නැහැ කියලා ගෙදර ආව බය වෙන්න එපා කියලා ක්ලෝරම්ෆිනිකෝල් දීලා ගෙදර ආව දවස් 3කට පස්සේ child came with the eye was a pustule in Ratnapura hospital. Eye was a pustule and had to remove. So lost the eye. Would have salvaged the eye if the doctor knew that. Cannot blame because we have not told them. So if the doctor knew that even a tiny suspicion of foreign body into the eye, he'll have to treat. Another story I will tell you. You will not forget these things. From one young boy, 23-year-old boy, he was walking on the road in Panasura bus stand. Suddenly, foreign body came and hit the eye. Nothing but severe pain, and came to the eye hospital. Treated, sent the patient back. In 4 days' time, came back to the eye hospital. Severe endophthalmitis. Course එක මම quickly කියන්න. අර බස් එකේ යනකොට ටයර් එකේ there was a chip, a small the rock particle slide against the tire, and it came and hit into the eye. It went into the eye, tiny piece. Patient couldn't, nobody, even the doctor couldn't find the entry wound, but came up with the endophthalmitis. Then the patient was referred to me when I was in Jawadharapura from the eye hospital. At that time, eye hospital, so much of patients. And then I operated, or some other political reason, I operated but couldn't salvage the eye. We salvaged the eye, we couldn't get the vision back. So very important, silent material can go into the eye. Okay, fine. So you can get similarly corneal foreign bodies. You can get corneal ulcers, especially farmers. Right? Look at this picture. Now here, this is a corneal ulcer. මේ පාට කරලා තියෙන එක ඕගොල්ලන්ටත් බලන්න පුළුවන් as දොස්තර කෙනෙක් වෙන්න ඕනේ නැහැ. What you do, patient comes with severe tearing, pain, අමාරුයි. Sometimes maybe contact lens wear, guys. Abrasion has got infected, especially farmers, fungus, ulcers and all. Now, how do you identify? Beluham torch with a magnifying glass, if you have, you can see, or otherwise take the ophthalmoscope, put the ophthalmoscope dial into black 8 or 9, that ekin magnify kala balanna puluwan mehema cornea එක බැලුවම you can see the ulcer very clearly. And then if you want to stain like that, in the ward you get fluorescein, right? අපි ඩයි පාවිච්චි කරන fluorescein වලට you take fluorescein, put little bit of lignocaine, normal lignocaine that you use to inject, put into the eye, and then eye become anesthetized, and then put this fluorescein onto the eye. Fluorescein strips are there, පොඩි කඩදාසි කෑලි වල වගේ ගා පාට කරපුවා තියෙනවා. ඒක මෙතන නිකන් තියපුවාම soak වෙලා ටක් ගාලා greenish color එක යනවා. The fluorescein වල තියෙන the characteristic feature is absorb blue light and reflect green light. It absorbs blue light, reflect the green light. So you turn the ophthalmoscope, you have the blue light, you turn the blue filter and flash into the eye, and then it will absorb the blue light, fluorescein, and reflect the green light. Another important thing, the fluorescein will not stain normal healthy cornea. If the collagen is exposed, fluorescein will go and bind to the collagen. That is what has happened here, right? මෙතන collagen exposed වෙලා ulcer එකක් හින්දා ඒ ටිකේ දැන් fluorescein ඇලිලා තියෙනවා. blue light එක ගහපු ගමන්ම blue light absorb කරගෙන මේ fluorescein green light එවරනවා. Then we can see the area of ulcer, right? මේවයි නවතින්නේ නැහැ. But here you get ulcer because එතන නැවතිලා තියෙනවා fluorescein බේරෙන ටික නිසා. So that is how you identify ulcers. This is called staining. Very easy. Take the fluorescein strips. So pharmacy වල තියෙනවා fluorescein strips. Eye stain කරනවා කියලා. Even eye ward වල තියෙනවා. And this can be used even in your normal ward or even a general GP practice එකේදී ophthalmoscope එක with fluorescein lignocaine drop එකයි විතරයි තියෙන්නේ. Exactly you can see whether there is an ulcer. This is very important when something like that in dendritic ulcers. Look at this. What is this? Anyone? What do you think this? This is a very important thing that you should not miss. This is called, what is the shape here? this is kind of a dendritic නේ අර fern shape නේ fern කියලා තියෙන්නේ අපේ අර ගස්වල තියෙන පොඩි පුංචි අතු අර පොතාස් එක දා ගන්න පුළුවන් fern tree මේක නිකන් ඒ වගේ හැම පැත්තටම ආබෝ වයිටේ කියලා කියන්නේ හැම පැත්තටම මෙහෙට අතු විහිදෙනවනේ. This is a typical viral herpes viral corneal ulcer. These are herpes zoster hari herpes simplex hari virus එකෙන් තමයි දෙකෙන්ම කරන්න පුළුවන්. This is called dendrites කියන හින්දා we call it dendritic ulcer. I sometimes make a very clear then what you can do, you put fluorescein as I told you and stain and see, you can see like this. So very important, if you miss herpes simplex dendritic keratitis or dendritic ulcer, and if you put steroid, next day patient comes with severe infection. I'll tell you one story. In the night, you may remember, I was asked to I was called one of the very well-known actor, my friend, and then when I was operating, Dr. Mata Poddak carried my conjunctivitis. He knows conjunctivitis against. So over the phone I advise steroid antibiotic combination. My luck, evening when I went to that side to see patient, I called that fellow and got down to see the eye. It was a dendritic ulcer. Next day it would have been very severe ulcer, and and if that person lose the eye, I would have been a mess, right? And so that is how important. The message that I am giving you: never prescribe medicine over the phone. Tell, I want to see you, right? If you may prescribe, but put the blame to the patient, otherwise patient will put the blame to you. That's very important take home message with this thing. If for anything, because the when something goes wrong when you are treating the patients, I'm telling you this as a colleague, one day when you treat the patients, if something goes wrong, everybody, including the patient relative and your colleagues, will not be with you. They will be on the other side. So therefore, very important, don't prescribe over the phone, right? Okay, fine. Corneal problems can give rise to red dye. Corneal foreign bodies, corneal ulcer, that's right. So those are the only things that can cause red dye on the surface, either on the cornea or conjunctiva. Conjunctivitis, cornea, foreign body, ulcer, or viral keratitis, right? That can cause redness. The next, redness. I told you sometimes what happens, you can get redness around the this area, right? Circumcorneal inflammation, right? That is usually causing due to inflammation inside, maybe uveitis, maybe acute angle closure glaucoma. Those are the two common things that you can get, or otherwise endophthalmitis, especially after surgery or some intervention or trauma. If the patient comes with severe pain, in all those conditions, if the inflammation coming from inside the eye, very two important symptoms are there. What are the two important symptoms? I will tell you in the conjunctiva. If it is conjunctiva, no pain. Pain is very much less. Vision is not affected. If it is coming from inside the eye, totally opposite. Vision is badly affected most of the time and severe pain. Photophobia, difficult to look at the light. Why? Already iris se inflame vela thiyene. Light vajunga man iris එක constrict වෙන්න එපා. Pupil is reacting like that. But because the inflammatory tissue cannot move, and then you get pain. So patient will be photophobic. Patient is coming like that, covering the eye. Or cannot look at the light. Vision is reduced. Photophobia, reduced vision, and severe you know it. But I told right, evacuation is not important. On the front part of the eye is episcleritis. Under the conjunctiva, you can get inflammation here. Episcleritis. Episcleritis is mostly idiopathic and rest the collagen, other things, it can be collagen vascular diseases, herpes zoster or herpes simplex, like that, right? Idiopathic, the vasculitis, that's rheumatoid arthritis, SLE, that can cause scleritis. The episcleritis. Episcleritis is when you look into the eye, you can very clearly see it is not really the conjunctiva. Underneath the conjunctiva, blood vessels are dilated. It could be nodular, tiny nodules, or it may be diffuse episcleritis. One cardinal feature of episcleritis is it is recurrent most of the time, and it is not uncommon. Recurrent. May maase hadino ay satit maasa dek tuningin ay eno ratu vela. So that's episcleritis, and not in severe pain, little bit of irritation. Right? Self-limited most of the time. You can use steroid. You can use steroid, but the danger of putting the steroid is what happens. A steroid can give rise to cataract. This is again very common. When you put steroid, what happens? Patient comes with glaucoma and cataract. Those are the take-home messages that you'll have to remember. The steroid can cause topical steroid. Today I operated 2 patients, young patients in their 40s, and one patient, 17-year-old girl, due to use of chronic use of topical steroid has causes cataract and can't see. What to do? You have to operate. So therefore, these people will tend to use steroid, topical steroid, but when you're putting the topical steroid, you will have to tell them continuously you can't use without advice. Okay. The other component that I forgot to tell you, scleritis, inflammation of the sclera, even be deep to the episclera. So you can get scleritis. How do you differentiate scleritis? It will be diffuse, bright red. Again, when the sclera is involved, severe pain. Patient will come like that. Scleritis, not like episcleritis. Episcleritis, conjunctivitis has relatively no conjunctivitis, no pain. Episcleritis, little bit of pain, but scleritis, severe pain comes like that. Causes trauma, idiopathic, inflammatory conditions like collagen vascular diseases, the whole range, rheumatoid arthritis, all things can cause scleritis. And you can see a lot of things, no? Chemical or physical agents, infections, metabolic causes, granulomatosis, like even TB can cause that, or toxoplasmosis, collagen vascular diseases that can cause this thing. And treatment systemic non-steroidal anti-inflammatory drugs, or if it is not responding, you can use steroid. So sometimes scleritis is also recurrent and very difficult to treat. Okay, so in the front part, I told you causes for red eye, conjunctivitis. Very easy to remember, bilateral most of the time, painless, tearing, vision not affected, usually watery discharge if it is viral, if it is mucopurulent discharge, pus-like thick discharge if it is bacterial. Treatment is topical, antibiotic steroid combination of antibiotic, and cold compressions. That's conjunctivitis. Next, I told you, beneath the conjunctiva you get the sclera, then you can get episclera. You can get episcleritis. It could be nodular or diffuse, recurrent, less pain. So then comes it, most of the time, not all over, one area of the eye, episcleritis, inflamed, or sometimes can be diffuse, or the whole eye is involved. So episcleritis you manage, again topical steroid. If you see all those things, topical steroid. And then deep to that you get the sclera. Patient comes with severe pain, scleritis, and associated with systemic conditions like collagen vascular diseases, and then managed with non-steroidal anti-inflammatory drugs. Usually those episcleritis and scleritis unilateral, but conjunctivitis bilateral. And scleritis, your vision can get affected because there is inflammation reflected to the retina and choroid, and scleritis can be affected posteriorly also, which you call posterior scleritis, because sclera throughout the all around the ball, but conjunctiva and episclera only in the front part. So okay, fine. Then I told you red eye, another cause is something damage in the cornea, especially foreign bodies or corneal ulcers. Then management, you have to remove that foreign body. Foreign body removal is very easy. You put a lignocaine drop and take with a cotton bud if you can clearly visible. Otherwise, you'll have to see magnified view and see. And you can stain exposed collagen in the cornea by putting fluorescein staining, and then using the blue light with the magnifier, you can see in the ophthalmoscope. So that's how you see the ulcers. And then if something inside the eye, patient is, the presentation is different. Vision is cardinal features, vision is less, severe pain. Circumcorneal inflammation. 3. Circumcorneal inflammation of the conjunctiva. Severe pain. Vision is lost. These are not hard and fast rule, but those are the common things, right? Common things, common. So you get that thing. And when you see the patient, then you can find the patient. It could be inflammation, it could be infection, it could be bleeding inside the eye. Those are the common things. Inflammation, either it could be iritis or uveitis. Infection, endophthalmitis, toxoplasmosis, anything like that. And bleeding due to hyphema, as I explained to you. I think because now most of the students also may be feeling now fully tired. Shall we continue from here next time? What's the time now? 1 hour. Shall we continue from here next time, or you want me to continue? I am not tired. I am free. Somebody can, next time I will try to record it. I will record and put it into your
No.
Yes. What do you want? Students, what do you want me to tell? Malaysia?
So shall we continue next day?
Right. Continue.
Okay.
70 or 70 with around 68 students. Morning 100 with then so we will continue next day. Today is Tuesday. Later at tomorrow I'm surgery. Thursday night also probably I will be able to do.
Okay, sir.
We will have a short notice again.
Okay, sir. Thank you, sir.
From point onwards, we will discuss.
Okay, sir.
Okay. Thank you for joining. Good night.
Okay, sir. Thank you very much.
Thank you,
Thank you,
sir.
sir.